to introduce my colleague, Dr. Kasia Chawarska. Kasia is an expert on autism as it appears in infants and very young children. When I first started work in the field back in 1980, in the olden times, seeing a 4-year-old was a young child with autism. And you would come and say, oh, come look, 4-year-old. And these days, I think the youngest child we've seen and we're worried about for a research project was 3 months, and in the clinic, what do you think? So it's a very different situation, and it's fantastic because we think the earlier we can intervene, probably the better the outcome. So this is a very interesting area. The other thing that's very interesting about autism as it shows up in infants and young children is we get to see autism as it develops. And we think that may tell us something about what autism is and how the brain is involved and what parts of the brain are involved, but also may give us some clues for intervention as we think about what are the things that are thrown off. So, Kasia, it's all yours.
Thank you very much. It's a great pleasure, as usual, to be here. I have a bit of a cold, so I might be speaking a little low. I hope you can hear me in the back. Is that okay? Yeah. All right. So in real life, I wear two hats. On one hand, I'm a director of the Toddler Developmental Disabilities Clinic, so I'm involved in a lot of clinical activities, and you will see some of that work reflected here in this talk. But I also run an early social cognition lab in which we study expression of autism on a somewhat micro level, experimentally, asking questions how children with autism process information, social information, particularly information about faces. So as you might have today in this talk, I'm going to talk a little bit about the onset and diagnosis of autism, how autism expresses itself in the first 3 years of life, and then I'll give you a quick preview of our work in the lab on face processing. You might have learned thus far in this course that autism is a complex neurodevelopmental disorder. Its symptoms can be quite severe and are expressed in two domains, primarily in social interaction and communication. Children with autism also have tremendous difficulties with another class of problems. They have unusual sensory interest, they have some unusual body movement, and quite repetitive or stereotyped interests. Symptoms of autism become apparent in a vast majority of cases before the 3rd birthday. However, diagnosis is typically delayed. Still in the US, as Fred mentioned, many years ago a child wouldn't be diagnosed with autism until the age of 6, 7, or 8. Right now, still, we do not diagnose a majority of children until the age of 4, which is a major problem in the field. Autism is a pervasive disorder. It affects multiple areas of functioning, and is characterized by incredible heterogeneity of the expression. Children who are affected by this disorder vary along a number of dimensions, including level of cognitive ability. There are some children who are very profoundly affected in terms of their IQ, and there are children who are very bright in selected areas of functioning. Some children with autism will never develop speech. Others are very verbal or even verbose. For some children, proximity of other people is quite disturbing, and they, in fact, avoid contact with other people. They are quite perturbed when being approached. Whereas other children might be actually quite interested in interacting with other children. However, they have tremendous difficulties understanding how to navigate through this complex and ever-changing social environment. Now, autism is also a developmental disorder. What does it mean? Well, it means that its symptoms change depending on the child's age and cognitive level. Consequently, if we think about the first 3 years of life, this is a time in development which is incredibly dynamic. Newborns begin as well-regulated systems which can process a lot of visual and auditory information. They cannot walk, they cannot talk, and by the age of 3, they not only walk and talk, but they can also cheat, and they are very sophisticated in their understanding of the social world. So it makes a lot of sense to ask how symptoms of autism can be expressed in a 6-month-old system versus a system that is 18 months old or 24 months old. And for that reason, we here at the Child Study Center, we've been very interested in studying expression of autism in the first years of life, not only for diagnostic purposes, not only so we can detect these children very early on, but also so we can understand the underlying mechanisms of social disability and hopefully design better treatments so that we can prevent secondary symptoms from emerging and perhaps even, I wouldn't say prevent autism altogether, but enhance the quality of life of children to the extent that is beyond imaginable right now. Now, so as I mentioned, symptoms of autism emerge in the first 3 years of life. We don't know exactly when. And so to address this question, a few years ago, we did a small study in our clinic when we asked parents of children who came for a differential diagnosis with their children, when did they begin to worry about their child's development? And now, as you can see here on the x-axis, we have the age of the child starting at birth and ending at about the second birthday. And as you can see, the distribution of parental age of concern is very broad, with some parents worrying shortly after birth, others not noticing abnormalities until after the first birthday, and still other parents saying, you know, everything seemed to be going okay until almost the second birthday. Now, so when we look at this, when this graph, a question presents itself, well, why? Why is there such variability in the report of the parental when parents begin to notice the first abnormalities? Why there's such variability? Do parents simply differ in terms of how perceptive they are, or perhaps there's something else at play? And in fact, when we reviewed literature on onset of autism, there are several interesting things which come to the foreground. First of all, there appears to be several patterns of onset of autism. First one is called the early onset, and it maps pretty well on what Kenner described in his initial cases, saying that autism is innate and abnormalities in social domain can be noticed already within the first weeks, if not months, of life. However, a few years later, Eisenberg and Kenner noticed that, well, perhaps this is true, but also they found another group of patients who seem to be developing typically until the age of, let's say, 18, maybe 20 months, and then gradually or suddenly they seem to lose the words they were developing, and they seem to withdraw from the social interaction world. They call this phenomenon a setback phenomenon or aggression, and current estimates suggest that there might be about 15 to 30% of cases with autism who experience this particular type of onset. Still, if we look a little closer at the development of children with autism, we also hear reports from parents that the child might have be developing all right until about 12 months, maybe 14 months, but then nothing happened. As if a child reached a certain plateau or their development stagnated and they cease to acquire new words, they cease to acquire new social skills, and for a long time there's nothing new happening in development. And we call it a plateau pattern. Now, this is quite fascinating. However, I must tell you that we don't quite understand these patterns of growth. We don't know whether these patterns of onset are in any way associated with, let's say, specific etiological mechanisms. Are they associated with a different developmental trajectory and outcome in these children? And the reason why it's happening is that for many, many years, in order to study the earliest expression of autism, we had to rely almost exclusively on parental retrospective report or on reviewing videotapes or video diaries recorded when children were very little, and then when the child was diagnosed with autism, someone could go back and review this diary and see whether certain abnormalities could be apparent or not. Now, there are a lot of advantages to these kind of retrospective methods, but there are also many methodological problems, most of them having to do with selection bias of the information we collect. So there's a new methodology around, which has become extremely popular in the past, I would say 5, maybe 10 years. This is the idea of studying autism in statum ascendi as it evolves. But in order to do that, remember that we typically do not diagnose autism until later, in the 2nd or 3rd or 4th year of life. So how can we actually study development in the 1st year of life, right? It's a very it's a complicated question, but it turns out that genetic findings suggest that once a child is diagnosed with autism in a given family, the recurrence risk of autism in the same family is much greater than we would expect in general population. As you heard, autism has a very strong genetic component, and for that reason, we expect this increased recurrence rate within the same family. The recurrence rate estimates right now are about 5 to 10%. That might change as the new studies come to fruition. It may actually go a little up, but the conservative estimate is probably between 5 and 10%. Now, so these younger siblings of children with autism are at higher risk of developing autism, autism-related disorders, and they also might have experienced some delays in language, cognition, and social functioning, which do not meet necessary diagnostic criteria. So they provide a very ideal cohort to study symptoms of autism and the mechanisms underlying it very, very early on. And here at Yale, we've been involved in this kind of study for 4 years right now, and I can tell you it's an incredible undertaking. In order to find 10 children with autism, we need to see 100 siblings. In order to really understand what's happening, we see them every 3 months, starting at birth, 3 months, 6 months, 9 months, 12 months, 15 months, 18 months, 24 months, 36 months. Imagine, multiply it by the number of kids, the number of visits. It's an incredible, incredible enterprise. But it is very, very exciting. So let's talk for a moment what we have learned thus far from these baby SIP studies about the expression of autism right then in the 1st year of life. Before we move on, I would like to give you a little bit of a rationale. Why would be even remotely looking for symptoms of autism in the 1st year of life? What would we looking for? What are we looking for? All right, so this is like a very brief summary what's important to know about the development in the 1st year of life. When babies are born, they come equipped with a number of very important perceptual biases, which helps them learn about the world a great deal. One set of these biases has to do with priming them to detect face-like patterns in the environment, and once they detect faces, they latch onto them. They look at them preferentially. They also preferentially orient to sources of speech or language, which brought together gives them a wonderful set of skills to find people in their immediate environment and to attend to them. This is a great way, great opening for learning about people and developing more sophisticated social and cognitive skills. When we study face perception, it's a very interesting question whether, for instance, in autism, children might be born without these innate perceptual biases, which would help them learn about faces. So that's one of the questions we are pursuing in my lab. By about 3 to 6 months, infants play very interesting games with adults. They begin to engage in something that we call dyadic social interaction skills. So the mom smiles, the baby coos, mom coos, the baby coos back. The reciprocity is beginning to emerge and is incredibly reinforcing to both sides. So you can jazz up the baby by simply playing the game and repeating what the child is vocalizing and smiling. By 6 to 9 months, children are beginning to show more sophisticated skills with regard to face processing. They are not only very good at encoding facial identity within seconds, remembering it for minutes, hours, and days, but they also begin to categorize faces with regard to affect, gender, and so forth. They begin to recognize certain words and respond to them differentially, in particular their own name. And the simple dyadic anticipatory games become more sophisticated, taking shape of a peekaboo game and so forth and so forth. Between 9 to 12 months, several wonderful skills begin to emerge. First of all, babies monitor other people's behavior even more intently than they do before, and they also begin to actively imitate their behavior, which is a marvelous way for learning new skills. They also begin to monitor faces of other people for their facial expressions, and they derive a lot of information about the world from what's mom's face like. For instance, if we present a child with a new toy and the toy is a little scary, the child might look back to the mom. If the mom is smiling, the child will approach the toy. If mom is frowning, the child is likely to scoot away. It's a very important channel of, again, it's a very important way of learning about the world. Also at this age, children begin to communicate their needs. They communicate their needs via various vocalizations, gestures, squeals, angry shouts, pointing, but they also begin to communicate for another reason. They begin to communicate to share their experiences with others. By pointing things to them, showing it to them, and giving it to them, we call this set of skills joint attention. The reason I'm mentioning all of these skills is that many of these skills are actually affected in toddlers, in 2-year-olds with autism. And the reason why we are going back to the first year of life, that many of these skills actually have their roots already in the first year of life. So what have we learned about autism at 6 months? Well, I think when we all went into this business of studying baby SIBs, we expected that by 6 months we'll be able to see some symptoms of autism in children who are later diagnosed with autism. And it doesn't seem to be so based on the very recently published studies from other labs. It appears that children who are later diagnosed with autism are quite similar with regard to eye contact, affect, some very basic interaction skills, as well as verbal and nonverbal skills compared to those who do not end up developing autism. And there's an emerging consensus in the field that these symptoms are beginning to emerge between 6 and 9 months, further to intensified in the second year of life. And that's possibly just so. Maybe this is just the natural course of autism, that we will not be able to see anything absolutely any strong indices of autism at 6 months. But it is also possible, being skeptical as we always are, it is also possible that the methods we are using, the instruments we are using, are not sensitive enough to detect more subtle abnormalities which are related to pathogenic factors associated with autism. And I'm going to come back to this point in a little while when I give you a little bit of a case study later on. So by 12 months, again, emerging consensus is that by 12 months we might begin to see some differentiation between children who end up being diagnosed with autism and those who don't. Some of the important areas of impairment, this unfortunately doesn't work on this either, is the fact that children with autism show quite limited response to name. And this is not because they don't understand language or they have impaired hearing. There's something about the word. There's something about the name. It's not a regular word. It actually represents a very complex concept, which is a concept of self. And children with autism have tremendous difficulties responding when their name is called. There are reports of limited eye contact, limited use of communicative gestures, some delays in language, and also emergence of atypical, the third group of symptoms in autism, emerges of atypical way of exploring objects. Our colleagues from the Mind Institute reported recently a study in which they say that children who later are diagnosed with autism tend to play with objects in a more atypical way, spinning them more often than other kids, and also examining them visually in a more prolonged and intense manner than other children. But the first year of life still remains a frontier for us when we are still very actively studying both the symptoms and the underlying mechanism. From the clinical standpoint, we are much better informed with regard to symptoms of autism in the second and third year of life. A lot of work have happened in the past 3 years to contribute to that success. When Fred mentioned that in the 1980s seeing a 4-year-old was very unusual in a clinic, when we started the toddler clinic in the year 2000, we were primarily seeing referrals of children who were 3 or 3.5. Seeing a 2.5-year-old was very, very early, very, very unusual. Right now, I would say the most frequently, the age of referral is around 18 to 20 months, which has dropped quite significantly in the past 10 years. I'm going to go quickly through some of the most well-known and studied symptoms of autism in the 3 key areas. Normally I would show you some videos. We are trying to limit the number of videos which contain privileged information in this particular presentation. So I'm going to describe them to you and then show you one single case study a little later. I think one of the most striking things that happen when you walk into the waiting room when there are parents and a toddler waiting to be evaluated is how little your entry matters to this child. It takes a lot to attract the child's attention, to make them notice that you actually enter the room, let alone to respond to a greeting. Children at this age are very interested in exploring their environment. We see a lot of climbing, a lot of exploring toys, touching them, moving. They often like toys which create immediate effects. We call them cause and effect toys, when they push a button and something happens, and they can get engaged in this activity for a prolonged period of time, to the extent that interactions or an attempt to regain their attention can be quite unsuccessful. When we try to engage a child in a reciprocal interaction, it's usually quite hard, quite difficult. Children might actually enjoy greatly playing with an examiner when we show them some interesting toy. They might enjoy the toy very much, they might smile at the toy, they might stay with the toy for a long time, but there's no sense of shared activity. There's very low sense of shared activity and shared enjoyment. Our toddlers often make eye contact quite often. However, the quality of the eye contact is rather atypical. It doesn't usually occur when you expect it the most, and occurs sometimes when you don't expect it at all. It's often very fleeting, and it's not very well meshed with communicative bids and attempts to engage someone in an interaction. Our children often experience a range of emotion during one evaluation. They can be very happy, they can be frustrated, they can be even angry. However, what is striking, and this is a very powerful way of communicating emotional states to others, a very powerful way to communicate emotional states to others is to simply look at someone and make the face, right? You immediately communicate to mom that there's something not quite right and you need help. Our children experience all these emotions, but they very rarely direct them to other people. They do not communicate how they feel, and which makes their life, which makes the world even more so isolated. As I mentioned, children with autism at this age also have difficulties sharing the experiences with others, engaging in joint attention, and also they usually do not monitor behaviors of others to the extent necessary or seen in typically developing children, and they have difficulties learning via imitation. In terms of communication, it's a very interesting area as far as toddlers are concerned. The reason is that most of the children we see in our clinic at this age are primarily nonverbal. However, in order to assess their quality of communication, we still can focus on the nonverbal communication and various aspects of communication having to do with why they communicate, what kind of means they use, and how well they are integrated with social behaviors. For instance, our toddlers communicate very infrequently. A typical toddler communicates about 3 times per minute. A child with autism might communicate 3 times per half an hour. Now, children who do have language delays, and most of our children do have language delays, are capable of compensating for lack of language with use of communicative gestures, expressive facial expressions, and also eye contact. What we see is in autism we see lack of these non-communicative behaviors, lack of gestures, and inconsistent use of eye contact for communicative purposes. Now, some of our children actually do communicate occasionally, but primarily to get their needs met. There are 2 reasons why we communicate with other people. One is for instrumental purposes, to make them do what we want them to do. And the second, we communicate in order to share our experiences. We call it declarative purposes versus instrumental purposes. Children with autism can be very, very effective in communicating their needs. But what we see is this disparity in frequency of communication for instrumental versus declarative purposes. Now, for those where we see language emerging, we also unfortunately see that atypical features of language are becoming apparent. So a child might repeat verbatim what they just heard. If you ask them, do you want juice? Instead of saying yes, no, or nodding their head, they can repeat, do you want juice? With exact inflection, exact intonation. We call it echolalia. Also, there's another very interesting feature which we see in some, not all children with autism, but when we see it, it's quite specific to autism. We call this feature hand-over-hand gesture. If you ever come to our clinic and you have an opportunity to observe one of our toddlers, you might be able to see it. It's quite striking when it happens. It is a situation in which the child tries to communicate what they want, let's say they have a container which is tightly closed, they cannot open the lid, and instead of giving it to an adult with some kind of indication that they want it open, they might look around them, they grab the first hand they see, they pull the hand, they put the hand on the container as if they were using this hand as a tool, disembodied from the rest of the person. It has a very interesting feel when you are a subject of this kind of manipulation, and it's quite, as I said, we see it in some children, not all children with autism, but when we see it, it's a quite diagnostic sign. Children with autism also have deficits in play. Play early in development is very important for development of language and cognition. Our children tend to use objects in a typical way. When they explore objects, they often focus on physical characteristics, how the object feels, how the object smells, what kind of noise it can produce, or they focus on the details of the object. This is a picture of a little boy who likes to line up his toys, and that might be one of the primary modes of his play. Now, In young children, we see some of the repetitive behaviors and unusual sensory interests as well. Some children might be overly sensitive to touch, or might be very interested in certain types of motions. So we've had children, toddlers, who can spin pretty much anything from their shoe, plate, lid, pencil, anything. Some children also have develop interest in unusual activities and unusual objects. In this case, we have a little toddler who likes cans and likes to scan cans. We are also at this age just beginning to see the emergence of unusual motor behaviors and hand mannerisms. But these behaviors in this group usually are not very pronounced, do not have to be very pronounced in the second year of life. Now, autism is not only about deficits, but also about some excesses, and you might have heard that some children with autism have actually quite exceptional abilities. This phenomenon was for the first time described by Dr. John Langton Down, who noticed that some children with very profound developmental delays might have a specific ability in a one isolated area. And this ability might have to do with exceptional memory, musical skills, artistic skills, computational ability, and it's usually isolated from all other skills. Here I pulled a drawing by Stephen Wiltshire, who has unbelievable visual memory skills and drawing skills. Here he's drawing, I think it's a panorama of Tokyo, after a very brief flight over the city. I would encourage you to go to his website and actually see a few videos of how these drawings are produced. When we think about toddlers, we don't really see a lot of exceptional abilities, although some of our toddlers are very interested in learning about letters, numbers. Some begin to sight read. They can recognize signs, stops, exits, find them everywhere, read them out loud. Those who are verbal might have a very good expressive vocabulary. They might like to label objects. They might have actually quite extensive vocabulary for their age. And some of the toddlers we see have great memory for movies or books, and they can recite them verbatim. Presence of these kind of skills often might delay a diagnosis, because parents of an 18-month-old who is interested in their ABCs and can recognize all the letters of the alphabet, parents of a child like that might overlook the fact that the same child might not be interested in interacting with other people, and might not be using functionally on any of the language skills he or she has. Nonetheless, we see these skills in some children, not all children with autism. They tend to be isolated, not integrated with social interaction or more sophisticated play. They tend to be repetitive. Children who like letters will gravitate toward letters. They will not play with dolls. And in many kids, they are transient. They do not develop in special interest on unusual abilities. I think in my clinical practice, I've seen only a few children who went on to develop special skills. One of them was a little boy who I saw maybe at 20 months, who really loved shapes. He could label any shape, show him any shapes. He would see a table as a rectangle. Almost every object was reduced to a shape, which then he could label. It turns out that by the age of 5 or 6, he stopped being interested in shapes, but he developed interest in train schedules and routes of the metro system. So what do we do with all this information? We know, we have an idea what autism might look like in the second year of life, and then a child presents in the clinic for a differential diagnosis, and what do we do? How do we go about it? Well, rule number one is we step very, very lightly It's a very serious disorder. It's diagnosing a child with autism it's highly consequential for the life of this child and the family. And for that reason, we take this diagnostic process extremely seriously. Each child is seen in our clinic for 2-day evaluation. We bring on board 3, 4, sometimes more disciplines in order to better understand the child's clinical presentation and be able to sort out what might be driving the difficulties we see. Here I'm listing for your information an example of a battery of tests we would employ for an 18-month-old baby. As you can see, a large portion of it involves interviewing parents, taking very detailed medical developmental history, understanding whether there were any factors in the child's development which might potentially account for the difficulties we are seeing. We interview parents using divine and adaptive behavior scales to understand better what is the child's presentation at home. We can take a snapshot of the child's presentation in the clinic, but we want to understand how the parents perceive a child at home. What are the skills that the child demonstrates in the optimal environment? We also usually have 2 or 3 clinicians interacting with the child. The reason is we want to introduce different people to the child because each of us brings a different style, and we want to understand whether the observations we see are consistent across contexts, or maybe they are context specific. Maybe one of us had something very special that we were or not able to elicit from the child. In order to diagnose a child with such severe developmental disorder, we need to understand the child's developmental functioning in verbal and nonverbal domains, again to see whether there might be any factors which contribute to the child's social difficulties. We study their nonverbal communication very carefully, and also subject the child to a play session, semi-structured play session, which helps us evaluate the child's spontaneous level of social interaction and communication. Only when we have all these bits and pieces of information, we can get together with all the clinicians and begin to discuss what the diagnosis might be. Also, at the end of this process, we have a lot of information about the child, and not only important for diagnostic purposes, but also important for treatment planning for a given child. As I mentioned, diagnosis is a very serious issue at this age, and when we started running this clinic, we were asking the same question: how stable this diagnosis is. If we see a child at 18 months, 20 months, the child's presentation is consistent with the diagnosis of autism, how likely it is that this child will still present as a child with autism 5 years later. And we conducted a couple of studies here at the clinic, and it appears that the stability of the diagnosis between 2 and 4 is relatively high. And our colleagues in other centers also report a similar findings, which is quite encouraging, which means that we actually can predict to some extent diagnostic status of these children. However, there's a huge variability. Children move a lot within the spectrum. I just wanted to mention to you a study which just came out this month, in which we took a fairly large group of children, almost 90 children who were presenting for a differential diagnosis before their 2nd birthday. And we evaluated them very carefully and diagnosed some of them with autism, some of them with a pervasive developmental disorder not otherwise specified, which is a sort of a residual diagnostic category, indicated that the child has some social difficulties but not as severe as autism. And another group was diagnosed with non-autistic disorders having to do with non-specific developmental delays or language delays. And then when we followed them up at the age of 3, we saw that actually none of these children initially diagnosed with ASD converted to a non-ASD category, which means that we were pretty good at detecting autism when it was there. Uh, However, we also found quite a lot of movement within the autism spectrum. So there were about 25% of children who presented with very severe symptoms early on, and by the age of 3 or 4, their symptoms improved markedly. We see a movement in the other direction as well. So before I talk a little bit more about face processing, I would like to tell you a little bit about a case study, which might illustrate some of the points I made with regard to early expression of the syndrome. This is a little girl who is a younger sibling of a child with autism, and we had the privilege to follow her development starting at 6 months through her 3rd birthday. And unfortunately, she is one of the children who ended up developing an autism spectrum disorder. And by studying her development, we are learning quite a lot about how the disorder unfolds. I'm going to show you a very superficial, just a few things about her development as we are still working on the data and analyzing them. So in this slide, we summarize her development in the verbal and nonverbal domains. And on the y-axis, you have age at which we saw her for the evaluation, 6 months, 12, 18, 24, and 36. And on the y-axis, you see the mental age or age equivalent score on the Smolin scale of early learning, from which these scores are derived. Okay? And as you can see, both her verbal and nonverbal skills are progressing quite nicely. Right? At 6 months, she was right at the level. At 12 months, she was right on target. 18 months, we begin some differentiation between her verbal and nonverbal skills. She was very verbal. Her verbal skills are quite advanced. And by 36 months, if anything, she was more advanced than her peers. Right? Her scores are higher than we would expect, higher than 36 months. So just looking at her cognitive and verbal skills, we would have absolutely no reason to be concerned about her development. All right. However, we were also tracking very closely her development in social domain, which is the diagnostic domain for us in this case. And we, in order to study that, we used the Autism Diagnostic Observation Schedule. This was a toddler version. And we have 2 domains in which we assess the child's functioning: social affect and repetitive behaviors. And the way the scale is designed, that the higher score denotes a greater degree of psychopathology. And as you can see, at the age of 15 months, she was doing just fine. These are very low scores, nothing going on this particular scale. However, something terrible is happening here between 15 and 18 and then 24 months because we see marked deficits, development of marked deficits in terms of social communication, use of eye contact, affective communication, and so forth. So this is, just looking at this graph, we might say, this is when autism begins to develop in this low grade. We also see some increase in repetitive behaviors. The slope is much lower because the range is also smaller, and she did not have a lot of stereotypies, despite the fact of the marked social disability. I wanted to show you one more graph because it illustrates some of the special abilities we often see in toddlers. So this scale comes from the Vineland Adaptive Behavior Scales, and I pictured here for you the results from the communication scale. It's a parent interview and communication scale, captures the child's receptive and expressive language, but it also taps into the area of written communication. And as you can see, in terms of receptive expressive language, the girl is progressing over time just fine, as we would expect based on her cognitive scores. However, look at the verbal written domain. Unbelievable jump happening at 18 months to the point that at the age of 3, she functions more like a 4.5 or 5-year-old. And that particular jump reflects the special ability in her case, which has to do with her interest with reading, early reading and decoding. She's probably developing hyperlexia, and I think she might become a good subject for Jamie's studies in the future. So we might just end at that point. But when we saw her at 24 months and 18 months, and when we saw this big jump in terms of the emergence of symptoms of autism, we went back to the recording of the sessions we saw at 6 and 9 months. And I also went back also to notes of the clinicians who were seeing her at that point. And we noted that there were some difficulties or some unusual behaviors which we didn't know quite how to categorize. However, there were some things that were a little unusual. So the way we study social development in 6 or 9 month olds is we subject them to a series of so-called social probes. In this particular probe, a research assistant is sitting across from the baby and talks in motherese. Do you know what motherese is? Right, high pitch, baby directed talk. And she needs to stay there for about a minute or two and talk to the baby, and we record how babies respond. And in this case, we have a 6-monther who is typically developing, and it's totally mesmerized. This is 9 months.
Big smile. Hi. So exciting. It is. You are so happy today. Yay, good. You're walking around, and you're going to be walking too.
So in this particular case, we have a typically developing baby, motherese at 6 months. The baby is mesmerized. There are some smiles which she tried to insert in the research assistant's utterances. By 9 months, she's becoming much more active. She references her mom. She's having lots of fun. She fully appreciates and enjoys this kind of interaction. This is another girl. This is the girl we just talked about at 6 months. That's 9 months. And in this case, we see much less of this effect of sort of shared enjoyment with the research assistant. There's a lot of turning, twisting body away from the person who is trying to interact with her. And we saw this pattern repeatedly at 6, 9, 12, and 15 months, which might suggest there might be some more subtle signs in terms of expression of the social difficulties. And we are working quite intently on categorizing these signs or detecting the patterns which might differentiate children who later develop autism already at 6 and perhaps even 3 months. We also, apart from using these behavioral techniques in which we put a child into a room with an adult and we have them interact and we record their responses in the context of a live interaction, we also are trying to study their social cognition using somewhat different approaches. And I would like to tell you a little bit about the eye tracking research we do in our lab. Babies cannot do a lot of things. They cannot walk, they cannot talk, they cannot press the bar to tell us what the reaction time is going to be to certain classes of stimuli. But they can watch things, they can look. And actually, vision is, visual perception is one of the most important, apart from auditory modalities, one of the most important sources of information about the world starting from the very beginning. We know that scanning patterns of our visual scenes are non-random, they are goal-oriented, they are exploratory behaviors, and they are affected by a number of factors which are important, always important to consider when we study visual cognition using eye tracking. Scanning patterns are affected by the perceptual properties of the scene, having to do with motion, high contrast areas, color, sudden onset of the stimuli. They are very likely to attract our attention. But they are also driven to a large extent by the semantic properties of the visual scene. What we know, what the perceiver knows or thinks and feels about the perceived scene. With regard to faces, a very simple example is that we scan faces of people we know very well quite differently than we scan faces of strangers. Also, evidence from developmental science suggests that scanning patterns are likely to be affected by age. They change with age. And also studies on other disorders besides autism suggest that they can be affected by, for instance, schizophrenia, bipolar disorder, as well as autism. So in my lab, we are quite interested in a number of phenomena associated with face perception. And in this particular study, we have a 6-monther who is engaged in a face recognition study. We are asking this little baby to encode an identity of a new face, and then we test her on what she's learned using so-called visual paired comparison paradigm. You might be able to see this red dot here. I don't know if you can see it with the lights on, but this is her point of regard. And she's a marvelous looker, very attentive little baby. And here we ask her to compare the familiar face and the novel face, and that's pretty much end of the first phase of the experiment. What we do with this kind of data, we can summarize it globally by where the child is looking. These are a summary of her scan pads over this face you just saw. And as you can see, as an atypical 6-monther, she's not very, she's not terribly adventurous in terms of face scanning. She spends a lot of time looking at the eyes in a static image of the face. Just to give you an idea what kind of studies can be done, or what we do in our lab in terms of face scanning in infancy, we are interested, for instance, how face scanning changes depending on the context in which faces are presented. And in this particular study, we had a cohort of children follow from 3, 6, 9, and 12 months, and we showed them 3 kinds of faces. In one case, it was a static face, pretty much like the one you just saw before. In another case, in another condition, it was a image. It was a movie of a person smiling. So it was a dynamic stimulus. There was no speech, but there was motion and affect. And then we had another movie in which there was some motion, but the person was reciting a nursery rhyme. What was very interesting to find is that children actually adjust their scanning strategy depending on what kind of faces they are looking at. So if they're looking at the static face, most of the attention is distributed toward the eyes as compared to the mouth of the person. And it's true both of 3-monthers, 6-monthers, 9-monthers, and 12-monthers. When we look at the smiling face, the distribution changes somewhat. Attention to mouth increases, attention to eyes decreases a little bit. With the idea is that in order to read the emotion, you need to get information both from the mouth and also from the eyes to truly appreciate what is the person's affective expression. Things get even more complicated when we show babies' faces. They are talking because starting at 6 months, in this case, they begin to actually scan the mouth area more frequently than the eyes, especially when they are 6 and 9 months old, which we hypothesize helps them understand speech. There's a lot of nice perceptual cues in the way the mouth moves when we pronounce words, which provides some visual input and support for understanding language. So these are only typical babies. We will be mapping children who are developing autism onto these normative data to try and understand how much sensitivity we see in that cohort with regard to the types of faces children are experiencing. Now, I have no watch, so I have, okay, 5:30. We have still some time left. Yeah. All right, so at the end, I would like to talk a little bit about studies on face processing that we conducted on toddlers. We have cataloged pretty well the behavioral symptoms of autism. We know about joint attention, we know about deficits in dyadic social interaction, we know what kind of repetitive behaviors we can expect in children with autism. But symptoms of autism pervades also other areas of functioning, and one of the areas of functioning it affects is face processing. And from studies of older children and adults with autism, we know that they have difficulties in face recognition. They appear to employ different face processing strategies, which might be less effective, resulting in difficulties in face recognition. And also when they look at faces, they recruit somewhat different neural mechanisms to learn about them and to process them and remember them. Now, most of these studies were conducted on adults and school-age children with autism. What is actually interesting about faces, that face processing develops over a very prolonged period of time, starting at birth and reaching adult stages somewhere in mid-teens. And what we've learned thus far about face processing in autism, we've learned in a way looking at a certain developmental endpoint. And in order for us, what's very fascinating and very interesting to know is not only what the endpoint is, but how the children got there and what were the initial states of their face processing system. Whether these deficits were primary or secondary, do they emerge sometimes within the first years of life, or they are present there very shortly after birth. So with this question in mind, we conducted several studies on face processing in toddlers, trying to see whether certain abnormalities can be seen already in the second year of life. The first question, the first study I would like to talk to you about is a study in which we examined the recognition and also scanning strategies. In this study, we had two groups of toddlers, actually 4 groups of toddlers. 2 groups were diagnosed with autism spectrum disorder, and the other 2 groups were typically developing, and younger children were about 2.5 years old, and the older children were about 4. We tested them in a visual paired comparison paradigm in which first they were presented with a novel face, very much like the girl you saw on the video a moment ago. They were allowed to look at this face for as long as 10 seconds, and then we showed them a familiar face paired with a novel face. And the way our visual system and cognitive system is designed, once we learn about something or habituate to something, we tend to look at something new. So the measure of recognition is a ratio of the amount of time spent looking at the novel face as compared to the familiar face. And the way we process this data, we divide this visual scene, in this case a face, into regions of interest. And these are the key features, facial features, eyes, nose, and mouth, which then can be combined into the inner features. And we also consider outer features, which have to do with the forehead, cheeks, chin, and hair. These are the outer features, and everything else is a non-face or background. And we were very, very surprised to some extent by these results, but also quite encouraged to see that there are differences between groups, how they scan faces. First of all, these graphs are a little complicated, so let me walk you through them. We analyzed data on two levels. One level was the group features, inner features, which includes eyes, mouth, and nose, outer features, hair, and the other facial areas, and that's the background. In the second analysis, we zeroed in on the inner features, looking at the eyes, mouth, and nose. And I would like you to first look at the yellow and orange bars right here, which represent our typical controls. 2-year-olds in yellow, and in orange we have our 4-year-olds. And there's one striking feature there. What's that? What's that? There's no age differences, right? The bars are identical regardless of the age, which suggests that between the age of 2 and 4, typically developing children have settled on a certain scanning strategy, and it doesn't change between these ages. They tend to look a lot at inner features, a little bit at outer features of the face, and once we consider the key features of the face, they look a lot at the eyes, and spend about half of the time they look at the eyes looking at the mouth. However, when we look at the children with autism, we see several important effects. Some of the effects have to do with what happens when children grow older. And here we see a few concerning trends. One concerning trend is as these children grow older, they spend less time looking at the key features of the face. Instead, they begin to look away at the background. So in some ways, we see worsening of their scanning patterns as they grow older. When we look at the internal features of the face, we see one interesting finding, which is that children with autism actually look less at the mouth than typically developing children in these images. And I'm going back to this finding in a moment. We also see a trend of diminishing attention to the eyes as children grow older, but this was not significant. Now, when we looked at their recognition scores in terms of how well they recognize a new face, it turns out that typical children, as expected, have had no difficulties encoding facial identity and recognizing a novel face, familiar face. However, children with autism perform at the chance level. So similarly as their older counterparts reported in studies on school-age children, they also have difficulties in encoding facial identity. We are also interested whether there's any association between how they look at face and what they learn about it. So we examine their scanning patterns during familiarization with the performance during the recognition test, and it turns out that more restricted scanning pattern, more looking at the eyes, at the expense of looking at the other important features which encode facial identity, resulted in more poor performance on this particular test. So for some of you, there might be a question appearing whether perhaps children with autism have difficulties in general with processing information and learning about new things. And so we wanted to make sure that the deficits we see here are in fact face-specific. So in order to do it, we took 19 toddlers with autism spectrum disorder, and we run them on the two conditions, one involving faces, just the same as you saw before, and in the second condition we use objects instead of faces. And as you can see here, they showed a nice novelty preference for objects, but not for faces. So this deficit in encoding identity appears to be specific to faces, at least at this point. Another aspect of face processing has to do with regulation of attention. It's what happens before we actually engage in active exploration of the face. So in a very recent study, we asked a question whether there might be some deficits in face processing on other level than recognition, on attentional level. Faces are a very special, belong to a very special, very privileged class of stimuli. They are detected much faster than other objects. So if we present a face in an array of objects, you are much likely to, much faster to detect face than any other object you're looking for. And once we detect the face, our attention seems to be held by the face much more strongly than by any other object. In this respect, we talk about an increased cost of disengagement from a face that we see in typical individuals, and this increased cost is usually expressed in increased reaction time to peripheral targets. Now, from one of the previous studies, we had an accidental finding which suggested that this attentional processing of faces in autism might be affected. But in this particular studies, we wanted to develop a more in-depth understanding of this phenomenon. Children were tested in something that we call overlap attention cueing paradigm. I'm going to show you in a moment what it looks like. We enrolled groups of children with autism, developmental delay, and typical controls, and we studied their saccadic reaction time. The way we did it is following. It's a very simple experiment, extremely simple. In the non-social condition, we showed them this kind of mosaic in the center of the screen. It's a scrambled face, okay? And then after a second or so, a peripheral target appeared either on the left or right of this particular central cue. What we were interested in is how much time is it going to take them to initiate eye movement toward the target. In other words, we're interested in saccadic reaction time. Saccadic reaction time is composed of several components involved with planning a saccade, computing saccadic parameters, where you're going to go, and disengaging attention from the current fixation point. So the more you're engaged with a stimulus, the longer the reaction time is likely to be. So we tested them in a non-social condition, and then we created a couple of social conditions. In this case, this lady is doing all sorts of things with her eyes, and then the target appears. We make her blink her eyes and move her eyes to make her more salient, more attractive, rather than just a static picture. You notice that when we started this display, she was looking straight at the camera. In the second condition, we never let her look at the camera, with the idea that faces with direct gaze might have even more stronger attentional hold on typical individuals. We expected that typically developing children and children without autism will have greater difficulties disengaging from these two classes of the stimuli than children with autism, and we expected that in the non-social condition all the groups will be equivalent. And lo and behold, this is exactly what we saw. As you can see, in non-social condition, all the children are the same, and in the social condition, regardless of the direction of gaze, we see reaction time much shorter in the autism group, which suggests that their attention was not encumbered by the social quality of this particular stimulus. So based on the study, we concluded that faces do not elicit the same attentional bias in toddlers with autism as they do with children without social disability. And this effect seemed to be autism specific because we did not see it in children with other cognitive impairments. So the question arose, why is that so? Why would they be really disconnecting so fast from the face? Well, one hypothesis was that perhaps they are just faster at processing visual stimuli, so they don't have to look at them so long because they encode them very rapidly. It is quite unlikely that the speed of processing would be responsible for the current pattern of results, because as our previous studies showed, that they, despite the fact that they are looking at the faces, they have poor recognition skills. So it's not that they're processing the identity faster and they move away from the face. There's likely something else going on. So the second hypothesis which we are pursuing now or testing directly in my lab has to do with depth of processing. It turns out that anytime we look at any kind of stimulus, including a face, we can engage variety of levels of processing, or at least couple of levels of processing. So if we look at the face, we can look at the face almost as an object and think about its physical or perceptual properties. We might think about categorizing it. Is it a face or is it not face? Is it a male? Is it a female? Is it a redhead or is it a brunette? At that level, we do not engage in a lot of processing of a semantic kind. However, if we look at the face, we can also begin to think, well, is this someone I know? This reminds me of X, Y, and Z. Well, this person is really trustworthy. I would like to probably meet this person, or no, I would never, ever, ever would like to come close to that person in my life. And it turns out that depending on what kind of level we engage with the face, that the level in which we engage with the face actually affect how well we encode facial identity. So adults subjected to this kind of manipulation have difficulties recognizing a face once they were asked to focus on physical characteristics. If they were asked to focus on more semantic characteristics, their performance was greatly improved. So we hypothesize that it is possible that when a child with autism looks at the face, they might not engage with the face on the same level as children without autism. They might be looking at the face, they might be focused on perceptual features of the face, maybe doing simple computations having to do with assessing its gender or faceness, and not necessarily thinking, is it mom, is it nice, is it mean, and so forth. These are the hypotheses we are currently examining in our lab. So just to sum up quickly and leave a few minutes for questions, the studies on face processing in toddlers thus far show that they have atypical abnormalities, biases in terms of faces, deficits in face recognition, that the properties of their scanning, in particular restricted scanning patterns, might be responsible for less effective encoding. And also we are noticing very concerning trend suggesting that the face scanning might become more abnormal as children grow older. The next questions very important for us are whether these deficits are primary or secondary. Can we see them in the first year of life? And we are also studying other aspects of face processing, which might tell us a little bit more about the patterns of strengths and weaknesses that children with autism have in this particular area, and by that tell us a little bit more about the underlying mechanisms. The long-term goal and fantasy of people in my lab is that perhaps we can also design techniques to help children normalize their face processing skills, but that's something that it's sort of far, far, far away. In terms of early expression of autism, just a few words. Symptoms are typically apparent already in the second year of life, to the extent that they can be detected, quantified, and used reliably for diagnosing children. These symptoms can be, the diagnosis itself is relatively stable, but we do see tremendous variability in how the syndrome expresses itself in the first year of life and second year of life actually, and then what are the outcomes, with some children making tremendous amount of progress and other children making relatively low progress. The concerning part is that we do not understand basis of this heterogeneity. And one of the very important goals which we are working toward and other colleagues around the country are working toward is to understand, to parse this heterogeneity and understand its underlying mechanism. And I wanted to thank you for your attention and see if you have any questions.